Well, welcome, everyone. Thank you for having me up, and thank you for coming, too, because I don't want to just stand here and talk to nobody. The past couple months, and really year, have been pretty interesting. And honestly, I don't think you can look back and say when we've had a more interesting year than just what we saw in 2012. I mean, for any of our careers, really. I'm not just talking about the Supreme Court, I'm not just talking about the election, but all of the reform implications that have been going on, in some cases kind of quietly in the background. All the federal news is the news, but I don't think people are quite aware of how fast, how rapid, and how widespread a lot of reform is actually happening across the country. And that's what we're going to be talking about to some extent tonight. We're certainly going to hit on implications of the election, but I want to make this more of a discussion about where the broader elements and the direction of healthcare is really going here. All signs really point to the fact that we are entering an affordability economy. And more to the point, though, I want to talk about how we, or you, are going to best position yourselves as independent physicians, and in some cases aligned or even employed, to enter that, to not only survive, but thrive in that world. It's going to require an entirely different skill set from what you're used to right now. It's going to involve adapting our business models, transforming our business models. And I don't just use that word lightly. I mean truly transforming our business models and entering into contracts the likes of which we haven't really seen before, assuming more risk, providing more value, demonstrating more of our story. We haven't been charged in the way that we're going to be charged in the future. It's something we're going to have to actually embrace. All purchasers of all stripes are going to be demanding these changes. So, roadmap for the discussion this evening we're going to talk about. I'm going to start by really defining and explaining what I mean by the affordability economy, why I think it's so important, and why I can say, yeah, it has actually finally arrived. Next, we're going to dig into the question of how far and how fast the government, commercial payers, and even employers are starting to change. How are they changing their purchasing patterns, their preferences, and their demands to reward different measures of value, new measures that we haven't seen before. And finally, in the last section, I'm going to kind of step back a little bit. We'll consider a couple broader thoughts about what you, as independent, employed, or just aligned physicians, are going to need to do in this evolving purchasing world. How are you going to plot a course right now, today, tomorrow, when things are so uncertain? So by all means, when the opportunity arises, give me questions. I don't want anybody walking out of here with something on their mind that they didn't quite understand. So we may not have time in the bulk of the presentation, but I want to make sure we cover everything that you guys want to have covered. It's more of a discussion than it is a lecture in that sense. So given the fact, elections, yeah, there were a couple months ago, but still fairly recent, I'd be remiss if I didn't address them. A lot of people said, yeah, game over. We know where things are going. And I think, sure, as a result of the election, we have a good indication of the immediate future of how healthcare reform is going to proceed. But at the same time, I would just as soon argue that by no means has this been settled. Yeah, for the time being, it's the Affordable Care Act, but kind of like the villain in the movie you think is dead, but opens his eye at the very end. There may be elements that are still at work here. It doesn't resolve the underlying philosophical differences in what we're talking about. We know the position of the president, which is maintain the current system, to some extent iterative, to some extent transformative, but to proceed through two elements in the Affordable Care Act. It really does two things. One, expands coverage, and then two, it addresses issues of cost control. I think it's going to do the first fairly clearly through mandates. The cost control issue, that's a little less certain. That's dependent more on incentives and encouragement. So we'll see how that plays out. But the Affordable Care Act, though, has created a new entitlement, clearly. It increases the value, or it attempts to increase the value of the Medicare spend. That's the approach that the Affordable Care Act is taking. And they're going to do it through accountable care programs and delivery system reform. As you probably know, too, the Romney-Ryan plan took a different approach. They thought it would be better to shift the Medicare program to premium support. In that case, it would be a defined contribution, transferring all the risk to the beneficiaries and then relying on Mr. Market, in that case, to sort things out. So interestingly enough, though, some people looked at these as diametric opposing plans here, and maybe in the route that they took, yeah, they were, but the interesting thing is the Affordable Care Act went the iterative approach, the Romney-Ryan plan went the other way, but both of them had the same destination. The blank check in healthcare is going away. It's effectively gone. Both plans, in different ways, but both plans put healthcare on a budget. And that's a trend that we are not going to see reverse. You know, recent trends in spending have been encouraging, but simply put, as a country, we're broke. We just can't afford to keep doing things the way we're doing them. Just in the past couple months, I think the numbers are actually hitting home. You know, the country has gone addressing their own fiscal cliff. I think we're just getting to that point right now. There's some really painful decisions that are going to have to be made to address the fiscal mess that we're in right now. Right now, we're currently in sequester land. Depending on what part of the government you are, some of these cuts have already hit, some of them have yet to hit. A lot of the healthcare cuts are starting April 1st, just in a couple days from now. The bulk of them from the clinical side, 2%, effectively 2% across the board cut that we're looking at. It's about $12 billion in healthcare spending. You know, some people say, man, that's no good. But you're dodging a bullet here. If you think about it, we as providers should be relieved because the numbers on the table that are being discussed when healthcare reform, when really fundamental changes actually happen, we're looking at numbers that could be easily 10 times that big. Bigger cuts are yet to come. So the sequester may not be the worst thing in the world right now. But, you know, it's not, all of this is not all bad news. I can actually say there's some good news for once coming out of Washington. Number one, Medicaid is escaping these cuts. Some people would say, well, geez, what more can you cut from Medicaid? And yes, I think that's a fair counter-argument. But for once, there's actually some good news in Medicaid. The Affordable Care Act, a lot of people don't realize, there are elements in that will boost primary care reimbursement to the levels of Medicare. So, and initially, these were just lined up for the primary care providers providing primary care services. Recently, this was actually expanded to anybody, well, any provider providing primary care services. So some people are looking at a pretty significant boost in incomes. Also, the outlook for the sustainable growth rate is now a lot more encouraging. We'll get to that here in just a little bit. But regardless of changes in funding and whatnot, like I mentioned, you know, regardless of which direction things ultimately head, we can be certain of one thing, like was mentioned. Inaction is not an option, especially for the federal government. Right now, Medicare is stuck. It's in the middle. It's a passive fee-for-service model. It gets bills, and for the most part, it pays them. You know, but that's the worst position to be in for Medicare. It's got to do something. It has to become more aggressive. Either it can take the defined benefit approach, iterative, interventionalist, the cynics would say micromanaging things, or it can take the opposite approach, say, we're out of it. We're going to give you your defined contribution, almost akin to the pension versus 401k debate, and say, market forces will sort things out. And I think in each approach, there are winners and there's losers here. A cynic would say, Medicare is going downhill either way. But fair enough, things are going to change. Right now, as a result of the election, we're seeing things head down this route. But again, there's no saying that we might not see an eventual jump to that side. A lot of the payment reforms we're talking about, these are complicated. These are very big, unwieldy arrangements. We don't have a whole lot of track record with them. We don't know if these are going to work or not. So the jury is still out in a lot of ways. But if you put together all of these factors, these signs, these indications, it's clear that our largest purchaser, our largest payer, our largest source of revenue, the federal government, has to get more for its spend. It's going to demand more affordability in the care that it obtains from us. You know, if basic economics hold true, the way to spend less money is one of two things. Either you pay less for what you're getting over here, or you just don't buy as much. You know, that's the direction that by the way, all healthcare payers are heading. Like I mentioned before, welcome to the affordability economy. At the same time, commercial payers are scrambling here. They're trying to figure out how they can compete on value at the same time. We can talk more in depth about this a little later on, but example up here is Aetna. How they're reinventing their business model. The United Optums of the world and the Cignas they're all in the same position. They're saying, what's our strategy? How are we going to be relevant? And they're trying almost any approach they can. They're trying to support employers. At the same time, they're trying to partner up with providers and even becoming care managers themselves, partnering up directly with physicians. They're, in some sense, all over the place. In fact, there's an article, an op-ed in the New York Times not too long ago, Zeke Emanuel, and said, commercial insurers as we know it won't exist in a few years. Now, whether you believe that or not, there's an element of truth to that, and a couple reasons. Right now, 60% of non-Medicare individuals are covered by a self-insured employer. In that sense, the commercial insurers are claims processing firms. They're just pushing paper at that point, and that probably won't last. Second, as we see ACOs and ACO-like models develop, they're assuming more and more risk. They're including more and more of the population such that they're just saying, we're going to pool risk ourselves. We're going to assume the responsibility for the entire premium dollar. And the commercial insurers, as we know, just won't be relevant anymore. Interestingly enough, the CEO of Aetna agreed with just this. Optum has made comments along the same lines. The quote down here, it pretty much says it all. We need to move from a system from underwriting risk to managing populations. We want to have a different relationship with providers, physicians, and hospitals we do business with. Even they realize the future is going to be different. At the same time, that's opportunity for us. To that end, commercial payers are forming partnerships all across the country with almost every partner they can find. Both sides are hoping to provide new partnerships, new products, new services that don't exist right now and can lead to competitive positioning in the marketplace. For providers, when they enter these arrangements, hey, this is an opportunity to lock up market share. An example of this, Inova just partnered with Aetna in Virginia to form their own private products within the Northern Virginia market. Some of these have the narrow networks, some of them have an ACO or an ACO-like model in the process. For payers, though, and this is the ultimate relevance strategy, they have to make themselves relevant and valuable. They have to justify their existence. So we're seeing all number of iterations of this across the country. These things are already up and running. Like I mentioned, Innova's example, you can see some up here, locally here, the Blues in northern Michigan, heck, across the northern Midwest, have all kinds of programs right now. They're actually, in some sense, industry leading. The narrow network, for example, you're probably familiar with, where physician inclusion, by the way, is based on cost of care. These are things that 10 years back, what? Didn't exist. And that wasn't the criteria for participation in networks. This time, it's really different. The rapidly evolving employer market is heading pretty fast towards the affordability economy at the same time. Just recently, two prominent employers announced they were going to participate in a brand new private insurance exchange. Sears and Darden restaurants, they have the ubiquitous but nutritionally suspect Olive Garden and Red Lobster, just recently developed their own, in partnership with Ann Hewitt, developed their own private insurance exchange. So if you are an employee and you're covered by one of these organizations, they effectively give you the money to go out and buy insurance on the exchange. If you want better coverage than the premium would provide, fine. You can get it, you just have to pay for it yourself. So again, what I mentioned before, defined contribution, this may be an example of that idea that's still alive in the private world. So here's your money, spend it wisely. Now patients have skin in the game. They're being charged, they're on the hook for more that they didn't have before. As a representative from Darden had put it here, it puts the choice in the employee's hand, whether they want to buy up or down. Given human nature, I think when employees are looking at prices, we can probably guess which direction most of them go. And in fact, the early results were just reviewed actually in a Wall Street Journal article just a couple days ago. So far, yeah, actually a lot of them are buying down. But so far, a lot of people are happy with this arrangement. Darden loves it because they're saving money. They're suddenly risk and uncertainty and rising premiums gone. They know exactly how much money they're spending. They're spending whatever they want to, which is the employee premium here. Employees, at least up front, all of them are benefiting in potential cost savings. The catch, though, is we'll see how long, since everybody benefits up front, only a couple people get sick in every given year. We'll see over time whether the average experience changes with this. But for the time being, thumbs up on both sides. And Ann Hewitt is chomping at the bit to expand this model elsewhere to other employees, or other employers and employees in their organizations. Some providers are seeing the writing on the wall, and they're starting to prepare for a future where again, the employees here, when it's their money, are going to start buying down. Not only accepting commoditization as inevitable, but actively preparing for it. Here's one case, actually, out in the Southwest. In Phoenix, in Southern California, outpatient imaging, rough market. Intensely competitive out there. There's an organization called Bid on Health. If you're a patient, if you're a consumer, you go out, if you need an imaging study, you go online. You say, it's basically Priceline for imaging studies. So we know that there's just obscene discrepancies in pricing for outpatient imaging. Well, you can go down and bid it down to the lowest possible dollar right now. The back end, they've negotiated with all these independent imaging centers to provide that service at a cheap price. One example we've seen, typically it's like 60% off what would otherwise be the average list price. One person got an MRI for $300-something when they were originally quoted a $3,200 study. So it's a race to the bottom in price. And this is currently just in that market, but there's absolutely nothing stopping this from expanding elsewhere. So the fat margins, the price shifting and whatnot, models like this, these upstarts that are willing to cherry pick these profitable niches are going to destroy those little pockets of profit. Again, Phoenix is not typical of the rest of the country, but we're going to have to be prepared for these kind of changes. But still, though, this isn't value-based competition that I'm talking about that we're going to be entering. Honestly, this is really just enhanced pricing competition. We're talking about, there's no, I never mentioned quality here. Who does a better study? Who's got a better magnet in their MR machine? There's no quality elements here, but we're even seeing organizations that are starting to address the quality element here as well. One thing I will throw out, food for thought, something like this comes to town, this could really suck up some of our margins. Maybe. Or is it opportunity? What if you are currently the low-cost provider? What if you have figured out a way to do it cheaper because you've seen the writing on the wall and you've seen it coming? And the competitors, you can catch the guys across town flat-footed. So this is not all doom and gloom. Yes, it could threaten margins, but it could be a potential source of volume. So keep that in the back of your minds. We're seeing some providers take just that approach. Last point I want to make about how we're already in the changing environment, really it comes from some of the new alliances that we're seeing. Totally unexpected partnerships that nobody would have seen coming. One example is DaVita, when they bought up Healthcare Partners in Southern California. Dallas's company bought up a large primary care group. Not many people saw that coming. We certainly didn't. But if you stop and think about it, there could be an element of logic to it. We'll see whether it plays out or not. DaVita, we all know, they do dialysis. They have a specialist service, and they do it well. They do it across the country. They know how to scale. Healthcare Partners, they're dominant in their market. They know how to provide primary care to large populations, not just several practices, but entire populations within the market. So I think DaVita is saying, if we can get their knowledge of that skill set, we've got the scaling ability, we can scale that model across the entire country. At least that's the thought. So suddenly, we could be looking at the emergence of a franchise brand that's a nationwide competitor for primary care services, not just a local onesie-twosie arrangements. Again, I think there's a leap of faith involved here But we could be on the verge of an entirely new national model here that I don't think anybody saw coming just a year or two ago. If you're the competitor in town with these guys, and they're nationwide, it could be a race to the bottom on prices. It could become a very, very difficult market to participate in. So with that stage set, regardless of the direction in which Medicare itself heads, the private market is already pushing and pulling us into the affordability economy. With the reality in mind here, it's critical. We have to understand the evolving demands of our payers. They're customers. We have to know what they want. We can't just provide them what we want to provide them. So how are we going to offer more value to them? And importantly, what they see as value, not necessarily what we see as value. The imperative there about providing value, it's always been there. But figuring out what they value now, that's the new challenge because it's changing. What kind of solutions are they going to demand, or what can we expect from them? It's not the world of before where we're just working under the commercial model. Things are going to be quite different in that respect. And then in the process, what are we going to have to do to deliver that care? How are we going to have to reorganize ourselves? We can't just keep doing things the way we have been. Things like the patient-centered medical homes, new arrangements, direct-to-employer arrangements, we're going to have to be thinking. Those are the things they're going to be looking for. Are we in a position to provide that? Can we provide the seamless care across the continuum? Are we still going to be operating effectively as silos? That's going to be challenging, particularly as payers define value in different ways, place to place. So in the next section, we're going to start teasing through the preferred strategies that the three main providers, or providers of healthcare, payers, or purchasers are going to be demanding, so they can extract greater value themselves from the healthcare system. We're going to start by examining the demands of the government. They're our biggest payer right now. Bottom line problem, like I mentioned before, we're broke. As a country, we just don't have the money to keep doing what we've been doing. The trend has subsided recently. We're doing better on our healthcare spending. We're actually bending the curve to some respect. But Medicare still has been growing 50% faster than GDP for years on end. If that keeps up a couple years, healthcare is going to capture $1 out of every $5 of GDP. How do you begin to address a challenge like that on such a broad scale? I mean, the quote on the bottom here pretty much sums it up, especially here. Something has got to give. I think we're finally at the point where something is finally giving. Faced with this reality, we're likely to see the government continue to pull every lever it can to maximize the value of its Medicare benefit. Like I mentioned before, it's an iterative approach right now. It's an interventionist approach. So they're going to get their fingers more and more into the care that we provide. That's going to be the central theme of Medicare policy, really. It's also why we're going to see additional movement towards value-based purchasing on top of what's in the Affordable Care Act. Not surprisingly, a lot of the groups, the progressive groups that see the writing on the wall, are embracing this, positioning themselves to try to get ahead of some of this, because preparation takes a while. I know some of you already in this room are participating in delivery system reform efforts, the Medicare primary care transformation projects, the shared savings and the ACO arrangements, especially with the private world that you're in, and then the Blue Cross organized system of care. There are, I don't want to say a bazillion arrangements, there are many iterations in this in the private world, all of which are similar here, but the key is you're getting the lessons. I'll tell you from experience nationwide, a lot of groups haven't even begun to tackle the challenge, and they're going to wish they would have. It's a process that takes a while. So I want to walk through the government's approach here, and really the three main components of the Medicare strategy. They're going to be adjusting the fee-for-service schedule, what we know of. They're going to be linking fee-for-service to cost and quality more so than they ever have. At the same time, though, they're going to be experimenting and continuing to test new system delivery reforms through their Innovation Center programs. Can't talk about fee-for-service, though, without mentioning the SGR, the Sustainable Growth Rate. It's kind of the elephant in the room. That's been hanging over our heads essentially ever since it was created. The idea, well, if spending rises too fast, we'll fix it. Of course, year one, it did. It's been a kick-the-can problem ever since. The gap had gotten to the point where it would require about somewhere in the neighborhood of a 30% cut in Medicare funding just to get back to where it was. Recently, just until not a couple months ago, projections of fixing permanently SGR was about $238 billion. Where are you going to find that kind of money in the government these days? Not. Well, recently, they just revised the projections over the next several years of spending to the point where they think, well, it's only going to cost, I think, $138 billion to fix. Woohoo! SGR Fix is on sale. I mean, honestly though, seriously, a lot of people are saying this is our chance to get this fixed. And importantly, we're seeing word out of all corners of the government, CMS, Congress, the Obama administration, that, yeah, we got to finally do something about this. Everybody agrees. Probably the conventional wisdom is look to this summer for these discussions to actually take place. Honestly, they've got a bigger fish to fry right now. We don't want to even try to tackle this, but that's probably when you're going to see things change. So then the question is, okay, let's say this does change. So then what will happen? What is the government going to do? You know, any fix is going to be expensive, you know, particularly when you get into the nitty-gritty and then unfortunately the de facto specialist versus primary care tug of war that generally ensues. Here's some of the major proposals that have been put out there right now. Over the past year at the advisory board, we spent a lot of time talking about the MedPAC proposal. That's the one that gets a lot of the news. That's, in a sense, the harshest one, but it's probably the most clear-cut. The other ones are a little softer in the details. In this, specialists would take a 17% haircut up front and then be frozen for the rest of the decade. Ouch. That hurts a lot. You know, the primary care guys don't do as bad here. To a large extent, they're just frozen here, and that's considered success. You know, some of the other proposals are gentler. They don't cut quite as bad, quite as fast. The cost reductions aren't quite as severe, but more interestingly, there's a little bit of sunshine here that doesn't get a lot of notice. I'm not sure why. Embedded in current proposals in some of these here, an off-ramp for fee-for-service medicine, saying, yeah, if you want to stay on the fee-for-service train, which is heading in the wrong direction, you can do that. But if you're willing to participate in these new care reform models, you're immune from a lot of these cuts. So that's the government's way of essentially nudging you off fee-for-service. You know, there's a carrot and there's a stick here. Here's your opportunity to go willingly, and you can escape some of the hits that you're looking at here. These, again, are proposals. Nothing is set in stone. But there are there are more incentives than people realize to consider some of these new models. Bottom line, though, at the moment, still speculation. Pull out your crystal balls if you really want the answer here. As you know, several months ago, Medicare released their final rules on the physician fee schedule back end of November, beginning of December. A couple things to point out there. Primary care did pretty good in this, relatively speaking. You know, they are actually looking at increases, like I mentioned, increases in their Medicaid rates to equal Medicare, at least for the next couple of years. For some, you know, that could effectively boost, if you're in the wrong neighborhood, effectively 60% rise in income within these populations. Wow, that's huge. You know, that in some sense could actively bring some providers back into the Medicaid population that weren't participating before. If suddenly you can start to make the numbers make sense. Specialists don't do so well in these new roles, at least within the fee-for-service realm. You know, they're facing just straight out reimbursement cuts, reduction in bonus payments, and there are technical issues that affect them. For example, the radiologists and their procedural reimbursing the MPPR fees, if you will. These are elements too that are expanding to other specialties, cardiology, ophthalmology, lab services. So it's a little bit doomier and gloomier if you're the specialist here. The details are still to be worked out, but it's fair to say that the major strategies that we've seen directed towards reimbursement are actually starting to become quite real. A lot of flux in terms of Medicare reimbursement, but there's another issue at work right now. It's not one that's quite as near and dear as some of the things we're talking about, but it's the outpatient differentials. This is mainly a hospital issue right now, but I don't know if you guys are familiar with some of this. It was just recently in the papers for a couple of days. The difference between the outpatient physician independent billing fees, and then if you're doing effectively the same stuff, but you have a hospital name on your door. Sometimes those fees can be double, triple what would otherwise be paid if you're just an independent group doing that. So specialists are saying, or primary care is saying, the hospital's coming to us, they want to buy us. I wonder why. Well, the hospital's saying, great, we can take all that business, but we can generate provide the same service and double or triple our bills. Of course we want to do that. And patients are suddenly left in the lurch here. They're seeing their same services suddenly 2 or 3 times as expensive. Don't think that's going to last. I mean, CMS is not dumb. They are not asleep in this situation. Yes, there are reasons that the hospitals bill at a higher rate. They have capital costs. They provide services that independents don't provide. Fair enough. Double, triple, quadruple, no. So I think some that are selling to the hospitals are getting while the getting's good. But I don't think that's going to be a long-term differential that will persist. Medicare is looking, when they're looking for every dollar they can, this is just too juicy of a target to ignore. That can pay for an awful lot of special programs here. But again, it kind of comes back to the whole food for thought. Is this a bad thing or is this a good thing? Depends on who you are. If you're the hospital right now, you're looking at cuts. But if suddenly you can provide that same service in a low-cost setting with higher quality, and you can demonstrate that quality, have the numbers to back yourselves up, you could be in a great position to employers and to insurers. I mean, nobody's going to tell your story but you. But if you can compare yourself to the hospital system down the street or to the group down the street and say that, yes, it's competitive and we're the best, it may be an opportunity for volume here. This is not your money necessarily that you're losing here. So, there's a glass half empty, there's a glass half full approach to take to this. Something I'm going to mention, yes, this is a hospital slide, but it gives you an idea of what Medicare's thinking here. When you get to the value-based purchasing pay for performance, this is already underway. Hospitals are already being subject to the quality metrics, inpatient issues, readmissions penalties, who falls in the hospital, who gets the catheter-associated infections in the hospital. But their Medicare is moving away as these first round of measures have been in place. They had feedback, a lot of it negative, saying, well, let's go to more meaningful outcome measures, mortality data, and not just that, population data. We're not just going after little individual pieces here. We're saying, how much money do you spend? How healthy are your patients on balance? Which really gets into population issues. So the reason I bring this up is because if Medicare is talking about that to the hospitals, they're going to be thinking the same things with the primary care world. Fits and starts, but that's an idea of their thinking. We're going to see that extended out to everybody. And also, if this is what's on their mind, they're going to be looking to you for help to address these concerns. You're going to have to be their partners for readmission penalties or for keeping them healthy once they leave. So anything you can do to help them address these concerns is going to make you a more attractive partner, whether you're employed, of course, or whether you're aligned or just independent. They're going to need your help in this regard. On the Part B side, things that are directly relevant to us, you can't ignore what Medicare's thinking and how they're changing their approach to value here. It looks complicated here a little bit, but let me kind of do this to make it clear what's happening. The PQRS program started out as a bonus program where you get money, quickly turning into a penalty program if you don't participate and you don't hit those metrics there. That's essentially the gist of this slide. Over the next several years, we're going to see the carrot be replaced fairly rapidly with the stick. They're already building out the elements of this. They're starting to roll out the new value-based payment modifier in 2015, by the way, which is starting on data that's being collected right now. I do want to recognize that more and more activities are being tied to quality metrics. They're definitely metrics. To what extent they reflect quality here is certainly an element of debate, but they're getting better. especially as they evolve more towards the outcome measures and the population measures. We are still seeing organizations push back. Pioneer ACOs made the news the other day because they said, hey, we were the first ones in, and these rules are so unworkable, these metrics are so unreasonable, we may quit. We may bail out of the program entirely. That's an ongoing discussion. I mean, that's just over the past several days. So as hard as it is to negotiate with the federal government, we may still see movement in that regard. Before we close out on this segment, though, I want to make a couple quick comments about some issues regarding exploration, new payment, and care programs here. Medicare's been testing a lot of programs through their Innovation Center, including several different types of ACOs, medical homes, and similar arrangements. Spent a lot of time over the past year discussing some of the elements of this, some of the details, and like we've already mentioned, United Physicians here is already involved in patient-centered medical home initiatives, care transformation efforts, and whatnot. So at this point, we'll just get into a couple quick updates through the rest. Before I move on, any just vocabulary I need to clear up here? Does everybody follow the initiatives, the SGR, ACO, whatnot? Okay, just don't want to lose the attention, the comprehension there. So I want to start here quickly with bundle payments. CMS changed the bundle payments program. Initially, it was, hey, come to us, make a deal. Flat rate pricing, just give us one price, and we'll see what we can work out. Now, I think as they develop experience, they changed to a fixed menu. There's 48 bundles that you can pick from. If you want to pick something off the menu, great, but they're not open to the, whatever you want to come up with right now. Our understanding here, they're trying to make this more scalable across the country because they just couldn't have everybody with their own specific separate little arrangement. Just in January, CMS announced about 500 participants in the bundle payment program. So just like that, this became the largest care reform effort within CMS. The biggest trial program they have going right now. ACO World has been up and running for a while. Every year, or every round, there's quite a jump in participation. Just to clarify here, what I mentioned up here, these are just CMS programs. This doesn't even include the numbers for the private world, where there are probably a comparable numbers. As you can see, it's not just a geography issue of big cities and on the coast. It's just as much Paducah, Kentucky, New Bern, North Carolina, all in between. I mean, I don't think there is a single geographic commonality here or a market demographic you can just look at and say, oh yeah, they're ACOs. No, it's all over the place. Interestingly, though, what we've seen some of the independents react, about half of these organizations don't have anything to do with hospitals, interestingly. So hospitals necessarily aren't in the driver's seat here. Like I mentioned, the actual appearance of these ACOs was kind of interesting. A lot of hospitals thought, well, these physicians, yeah, they're going to need us. They need our capital, they need our IT, they need our business acumen. They can't pull this off on their own. Physicians, to a large extent, says, yes, we do need capital and IT and help, but we don't necessarily need it from you. They were finding support from a lot of other sources, not a lot of other sources, but from the commercial payers, even from private equity to some extent. Here, I want to mention up here, CHS Collaborative Health Systems, subsidiary of an insurer. Their model is basically they go into a private physician group and say, we'll front you the cash, we'll front you the administrative support, we'll provide all the back end, you go be doctors. In return, we split things. Essentially 50-50. And so if independent physicians don't want to have anything to do with the hospital or want to have basically complete clinical operational control over their model, they can go with these guys. And then the hospitals in that market could suddenly say, uh-oh, we are now at risk of becoming commodities. Can this ACO, and let's say in a smaller market, this one ACO, can it play hospital A off hospital B? Who's going to give us a better price? Who's going to give us easier access for our patients and provide better service? They're making the hospital respond to them. So hospitals are looking at, can we compete as an Apple or can we compete as a Dell? Low-cost provider is a pretty lousy competitive position to be in. Nobody saw this coming. And also, CHS is trying to create what they call statewide ACOs. Right now, you need a certain critical mass. And most of the time, ACOs are market to market. Either they're here or they're not. Well, CHS, because of their breadth, is saying we can take this practice here and that practice here all over a state and just knit them together in essentially a virtual, well, real, but a virtual ACO. that has a little bit of presence in many markets. So it's not like you just have to, are they too big or not? No, they can slowly spread across the state. Whether it's good or bad depends on your position or not. Most people didn't see this coming a couple months ago, or a couple years ago. It's just an example of how the market is truly different right now. So a lot going on in the ACO front. I am not going to read this slide to you, don't worry. Food for thought for later, because I want to move forward into the commercial world, see what's going on there. Oops, sorry. Yeah, to rehash something I mentioned before, commercial payers are really facing a question of relevancy. How are they going to stay relevant in the new world? Their business is shifting from being traditional insurers to somehow avoiding the trap of becoming claims processing firms, paper pushers essentially. In the national landscape, they say all their growth over the past couple of years has been in the ASO, administrative service only realm. They've seen negative growth in a lot of respects in their traditional insurance side. So they've said, what are we going to do? How are we going to survive? How are we going to be relevant? If they don't, they face becoming pushed out of the market altogether. The CEO of an anonymous organization said, we have to address the cost challenge. If we are going to provide a product, it has to be one that addresses the intense cost need of the employers, to some extent the employees too. If they don't move in the direction of better care, in most cases new value, employees just aren't going to be able to afford the care that they have right now. Indeed, a recent benefits management company had said that only a minority of employees or employers expect to be able to provide coverage for their employers in the future. So what are they doing? How are they responding? Three main aspects I really want to hit on in this regard. They're talking about patient steerage, narrow networks, and then entirely new patient models. All things that we're seeing, heck, even in this market, maybe more so than the rest of the country. I want to start with steerage here. Here's an interesting little nugget I'll throw out here. Anthem has a program. They call it the Smart Shopper program in certain markets. If you need an expensive outpatient imaging study, Anthem will pay you to go to a certain provider or a certain source to get that study. And I said they will pay you. They won't give you a discount. They will write you a check for up to like $100 to get your MRI done at Center X instead of maybe at Hospital Center Y with that double, triple, quadruple price. They can give you cash and still come out ahead. One employer that they partnered up with, they saved on average $500 per patient per year. Wow. That's just, I don't know if it's a sad reflection of the inefficiencies in pricing or if it's just an example of how aggressive they're getting. They're writing $100 checks every time they need these studies. But that's the kind of thing that we're seeing right now. Again, if you're the hospital, this is pure bad. If you're that low-cost provider and you're willing to step up and tell your story, it could be opportunity. The core strategy, though, that we're seeing for the time being is still narrow networks. It's a little bit of a dust-off of a 90s strategy here, but they're saying are the core preferred providers high quality, low cost. They are definitely interested in this because they're saying to employers, we can save you 10, 20% on premiums. That's kind of money that employers are definitely in tune to. They are opening their ears, opening their eyes, and they're signing up rapidly. These kind of things. Before I want to close out on that, I do want to mention what some of the commercial payers are doing with their own payment reform initiatives. Medicare, yeah, they're still testing their own models here. But I think the commercial side in some ways is actually spearheading some of these initiatives. We're seeing a lot of the really innovative ideas come from the commercial side because they're free from the restrictions that the federal government has. Here locally, I know Blue Cross Blue Shield has a couple programs out. There's the Michigan Primary Care Transformation Project. Things are already reality for a lot of you guys right now. Medicare it gets all the attention because it's the government, and everybody talks about the government, but watch the commercial space, the private side, because I think Medicare is actively looking to see their results so that they can steal their ideas to spread them nationwide. And we're already seeing an analogy of that in the Medicaid side. As the individual states want to experiment with them, the government's actually receptive to their ideas, and they willingly admit them. A lot of this, though, it goes beyond how the payers are just saying, we're just going to pay you differently. Commercial payers are just completely reimagining a lot of what they're doing, what they can be to providers and their employees and their covered populations. Here's just some of the solutions that United Health, who by the way, Optum, because they rebranded themselves in the new world, what they're doing. Decision support, care solution. I mean, geez, how many things are up here? They're throwing everything against the wall to see what sticks. They're trying to be everything to everybody. Not only are you trying to go to hospitals, hey, we'll be your partner, we'll have this new network. Insurers are opening up storefronts. Like you can go get your AT&T store or your Sprint cell phone store. Insurers actually have storefronts where you can go get insurance now, direct to consumers. That didn't exist a year or two ago. That's just an example of how far and how wide. Nothing is off the table. They're looking at everything here. The specifics aside, though, commercial payers are basically saying, we're going to be partners to whoever wants to be partners with us. We're going to try everything we can to figure it out. A couple final thoughts. Again, not reading this off to you guys. They're not going away. The commercial insurers are just going to look a lot different in the future than they are right now. For the time being, they're going to defend their turf. It's going to be the narrow networks. That's going to be the core strategy, but with a lot of experimentation going on the side. For the time being, I think the ACO model is something that they'll be pursuing, but it's not going to be the core of their strategy. And so you'll probably see more activity and more future experiments directed around that narrow network strategy. And with that, there's going to be winners and there's going to be losers in the market. A lot of times, what we've seen nationwide is they come in and what do they want to look at? Price. The successful participants from the provider side are the ones that are able to say, yes, we are low cost, but can also connect the dots. Maybe, what if you're 10% higher up front, but your patients don't get readmitted? Think about your long-term downstream value here. We've heard providers say, yeah, they completely ignore the fact that our quality outcomes are so much better because nobody's telling that story. As they form these narrow networks, the groups that we've seen have been successful are the ones that get proactive with their own data. They come out with their story, and they go to the insurers, and they say, no, we're going to control our message. Here are our numbers, and here is think of the car analogy, the total cost of ownership, not just the upfront sticker price. We are cheaper over the long term. Pick us, and we're better, of course. Got to mention health insurance exchanges. What are they going to be? I mean, in theory, they're coming next year, although probably practically speaking, they're going to be delayed a little bit. So one of the questions is everybody's saying, look, our employers are just going to push all their employees on the health insurance exchange. It's a valid question. Currently, projections are all over the place. I would not probably place a whole lot of faith on that number to say that more employers are going to be offering more insurance themselves. Wouldn't hold your breath on that one. I think it's going to be more likely how quick and how much they're going to be dropping employees on the exchanges. We're seeing any numbers anywhere from 10% to 30% of employers are going to be doing this. What's concerning, though, is the data on this side saying even if they wanted to keep employees on the rolls, they just can't afford to do it. Just in the past 5 years, 73% said yes, we will be providers. It's down to 23% in 5 years. They're just getting crushed by cost. This is the reality of their world that we have to acknowledge when we consider how we're going to respond to it. But what actually happens market to market is actually pretty complicated. It's not a simple answer here. A few variables I think are going to influence this. Depends on what market you're in. If you have a bunch of small, low-wage manufacturers that are getting just squeezed by cost, they're based on the nature of their employee base, they're probably going to be a lot quicker to use the exchanges as an off-ramp than if you're in a high-tech, knowledge-based world where you have to compete hard for talent, where health insurance is just part of compensation. Other factors, the insurance exchanges themselves, what do they look like? They don't exist yet, so we don't know. So employers are going to be hesitant. They're going to want to see what these things are like. And insurers are not going to know how the employers are going to react, so they're probably going to price things a little high to not lose their shirts. So I think what happens up front is not necessarily going to be representative of what happens in a year or two. But there's also the issues of, over that period of time, costs are probably going to keep going up. And really, what's acceptable, I think, is probably going to be evolving as well. Right now, employer-provided insurance is sort of sacrosanct. I mean, that's just part of the deal that we expect, for the most part, in American employment. More and more, as these become a viable alternative, you don't want to be the first employer to be the evil person to push your employees off. But once that dam breaks, we may see things flip fairly rapidly here. So I wouldn't look at day one or day two. Look at a year from now and see what's going on then. I think as these things become more acceptable, conventional, experience develops, I think we're going to see probably a lot more action than we were used to. So a lot of variables there. I think we have up here an example of merits, which is a benefits. They do a couple things, travel, rewards, whatnot. 2,800 employee company. This just sort of walks through their experiences. This is a typical company. Started out with regular insurance, started to move to, well, we're going to have wellness. Now we're going to have an offer of high deductibles. We can't afford anything but high deductibles. Can we afford to just provide insurance at all? That's the evolution of most employers these days, or the typical employer. And we have to be prepared to respond to that. Number one problem is affordability. They just can't afford it. It doesn't matter what they want to do. They just can't afford it. So right now they're looking at shifting more costs and partnering with new innovators for the costs that they still are responsible for. And there are upstarts coming out of the woodwork to take little elements of care or certain aspects of it to save them money on that to benefit themselves. Unfortunately, it fragments the market. It doesn't solve all of our problems. It makes life more difficult for us. But we have to acknowledge them. We have to be prepared to respond to them. Most employers right now are looking at high deductible health plans. That seems to be standard these days. That is the common thing. Even a couple of years ago, that was a novel idea for some. At work, when I would hear people talk, what is this benefit? They didn't quite understand it. Now it's, of course, everybody has it. Right now we're also seeing employers, it's to the point, this is outdated data. We don't have the most recent stuff up here. This is just becoming the only option at a lot of employers. It puts patient skin in the game. Patients are going to become consumers more and more. We have to acknowledge that. Some things are going to be a loss for us, but again, it can be an opportunity if we can justify our value now to the patients, if we can be that low-cost provider. Yes, ma'am? Consumer-directed health plans, effectively the same thing, depending on the setting. Yeah, for all practical purposes, the same. Yeah. Also, we're seeing kind of a dust-off of some of the old strategies. Reference pricing. CalPERS, if you get insurance through them, let's say for joint replacements. I think the list price right now is $30,000. If you need a new hip or a new knee, here's $30,000. We'll tell you where to go that you can get this done, almost like getting your car fixed in that sense. But if you want to go to a more expensive place, great, pay out of your pocket. If you want to go to a cheaper place, well, maybe you benefit from that. But again, this is the defined contribution versus the defined benefit. Another example of how this idea is not dying. If employers can't figure out how to partner with providers to influence costs on their own, they're just going to get out of it entirely. So we're going to see more and more of that in the private world. If we're in a position to respond to that, to be the low-cost provider, we're going to have all the volume probably that we would want. But the inefficient providers, the high cost, the ones that sit back and don't change are the ones that are going to get run over in the process. Wellness is also becoming a huge target within the commercial world. Cleveland Clinic, for example, has a program. You probably do yourselves. The more you participate in the wellness programs, the more you get your cholesterol measured, blood pressure measured, the more you save. They're saying you want to have a 21% increase in premiums, typical, or do you want to be held flat? Actually, for chronic care, realizing the cost savings, they actually discount their care up in Cleveland. They take all the soda out of the vending machines. They're trying to get rid of their McDonald's. Easier said than done, apparently. Actually, that was kind of ironic. When I was flying on the helicopter, we dropped patients off at Cleveland Clinic and be walking out. After dropping off somebody in the cardiac ICU, walk right by the McDonald's. Yeah, that didn't make sense, but they've recognized that. But it's the point almost where one of the employees actually said, walking out, they hide Coke in their filing cabinets, almost like it's the new scotch in that regard. But This is the reality. It's high deductible plans, compulsory wellness programs effectively. It's the new benefits baseline, but it's still not enough. Employers are saying we have not had enough relief from this. So they're looking at new tools to introduce ways out of this. Castlight Health is an example of a program. I don't know if you guys have ever heard of it. It's sort of like almost not an Amazon, but it's an online pricing tool. It provides, the idea is cast light on healthcare. What does a colonoscopy cost? Nobody has any idea. There's a study that came out the other day. What does a hip replacement cost? Somebody just got on the phone, called hospital to hospital in a market. Tenfold different in price that they were quoted, list price on hips. That's crazy. That's nuts. And Castlight is trying to do something about that, make it transparent. But at the same time, they're also providing review services online, kind of like Amazon or Yelp or whatever your favorite review service is. So if you think about this, there's a little danger. Think of the guy who writes 15 pages on why he got charged extra for guacamole. If you have to wait 15 minutes in your office because you were running late. That's the kind of stuff that's going to be available online. But not just, There's a dynamic that could change here too. What if you're the primary care provider and you refer this patient to Dr. Smith? Yeah, but it says Dr. Jones actually has better outcomes and he gets a 5-star from his patient, not a 3-star. What if your patients are pulling out their iPads and their iPhones in the office? That changes the dynamic. They're going to be looking this stuff up. I mean, you all see the people they're texting while you're trying to talk to them. They're going to be doing this kind of thing in the office. It's going to be different. Employers are going to be actively nudging patients in this direction. We have to be prepared to respond to that. Castlight, I'll just say that it's out. It's up and running right now, starting to make waves. Another example, I'm not going to get into Iora Health. Very briefly, it's a clinic that says, just give me the sickest patients you got. I don't want the healthy ones. Just give me the sickest ones. We know sick. This actually came out of the Atul Gawande hot spider articles. Did any of you guys read that? If you haven't, I strongly recommend it. It's a quick read. It's about 10, 11 pages available online. Find me later if you want it. Great article. It's Atul Gawande, Gawande is his last name. Atul, A-T-U-L, is his first name. He's a Harvard-trained surgeon. He makes me feel completely incompetent because he's done so much. He's a great writer. He's done a lot of writing about healthcare. It was an article where he profiled a primary care physician that went in and said, why are these patients so obscenely expensive? Went one by one, said, who generates the biggest bills? Why is that person expensive? Why is that person expensive? Why is that person expensive? Basically went to the fat end of the tail to analyze why some healthcare costs are what they are. They call it the hot spotters because these were the collection of the most expensive patients in the market. It's a New Yorker article. You can Google it. It'll pop up right away. Another thing briefly I want to mention, getting into issues of forming basically high-value networks here. Like I mentioned, the Iora example, some others are doing this as well. But essentially they're saying, how can we form networks that maybe even cut out the insurers? Like I was mentioned before. You're seeing self-insured rates grow to, oh goodness. It's going crazy the bigger you're getting. And even if they don't go to entirely self-insured, they're going to exclusive provider networks. They're saying, all right, you're in or you're out. We're not just going to provide access to all providers anymore. You're going to have to meet our thresholds. Different markets are seeing this play out differently. Sometimes they're establishing threshold. They're purposely playing the providers off each other, changing the rules just to keep them on their toes. More and more we're seeing these changes. This is a corollary here in the interest of time. I'm not going to go too much into it except to say that some progressive organizations are taking the iterative approach. Starting off small, maybe offering a couple services to the local employer. We'll just do wellness. We'll just do on-site clinics, slowly working their way in to a direct-to-employer arrangement. It's opportunity. Felton's a pseudonym clinic. We're seeing them do that right now with the goal of eventually becoming primarily responsible for that entire population. Again, it's opportunity if you're willing to take it. Some key takeaways here, won't get into right now because I kind of want to close out with some kind of final thoughts here in some ways. The reality that we're looking at here is pretty clear. It's a value-based economy. Value is displacing volume is the point of the realm, and that's going to be the key to success. It's not going to be a do more, get more. For some, for a while it will be. It has gotten us to where we are right now, and we'll continue to pay the bills. But increasingly, value is what we're going to have to be oriented towards. Now, financially, though, so we're going to say, how can we shift from a fee-for-service system that's on its way out, but isn't quite there yet, to this new value world, and not shoot ourselves in the foot? We don't want to get ahead of ourselves, because we'll give up all of this revenue with this wonderful new care, but reward the insurers, reward the people paying the bills. We can't do that. We also have to make sure that we keep our patients engaged. We have to keep them as part of the team. 8,760. Anybody know the significance of that number? Hours in a year. We see our patients, 1 hour a year total? What are we doing with the 8,759 other hours here? We have to find a way to keep them associated with our brand, our identity, keep them compliant with our care processes. Things we just have never been charged for before. In the ACO model, if we have them as our patient, they're our responsibility. What's to stop them from going to the other guy down the street and jacking up a big bill because they didn't like our care? Nothing. We have to keep them engaged. We have to make them willing participants on our team. And strategy-wise, we have to make sure that we're, like I mentioned, the flip side of all this wonderful care that we're providing is to make sure that we find a way to get paid for that care, to have the right risk models, to have the right contracts, and have the right partners, because we can't do it by ourselves. One question that some people say is independence, really, do we have a future here? It's kind of it's the biggest existential question. It's kind of scary. Some people say that there's reason to question that. The pipeline for independent physicians, not so encouraging right now. Some of the latest data, one survey said 72% of outgoing physicians exiting residency want to work for a hospital. They want the stability. They never knew it in the independent world. They don't know what, I don't say they don't know what they're missing, but they say we're totally on board. So we have to say, how can we justify our existence? How can we maintain our existence? I'm not saying you can't. I'm just saying it's a question you have to ask yourselves here in the future. Right? How many, several years ago, hospitalists, you heard of them. Right now, there's hospitals galore. Practices are being bought up left, right, center by hospitals. We're seeing all kinds of crazy changes. One example that was kind of funny, sort of, a small market, all the cardiologists were independent because that's just the way it was in that particular market. It was a cultural thing. Why a lot of people stay independent, it's just that's just the way they like it. Well, one two-man group in that town said, we're getting older. We're just tired of this. We don't want to deal with the billing anymore. Got a couple years back. Hey, Hospital A, you want to just buy us? And they said, talk. And said, okay, great. They formed a deal. And suddenly the market went from everybody employed to almost everybody. Well, all the cardiologists in the market said, wait a minute, what happened? What do they sell? What do they know? What do we don't know? Uh-oh. Within about 18 months, the entire market for cardiology in that town went totally employed. Didn't just stop there. It went viral. So all of a sudden, the orthopedist and the cardiologist, the OB-GYNs and everybody else said, uh-oh, what do the cardiologists know that we don't know? Uh-oh, are we missing out on something? And the market went from almost totally independent to the majority employed within the course of just like a couple of years. It was a feeding frenzy. And the problem is, everybody was making crazy decisions. There was no strategy involved. It was just, crud, what did the guy down the street do? How am I going to respond? It was knee-jerk reactions. Obviously, wrong approach to take. The reason I bring this story up, you can almost laugh at what happened is nobody had a strategy going into it. You have to say, okay, what is our identity going to be? What do we want it to be? Do we want to be lined up? Do we want to be partners with the hospital? Do we want to be employees? Do we just want to have a nice, cordial relationship? I don't know. Your answer, heck, different people in this room may have different answers, but you need to ask the question now so you can keep your head on straight when things do get interesting and heated. So you can make principled decisions that benefit you in the long term, not in the heat of battle. Hospitals are smarter this time around. Last time it was just buy practices up. Simple enough. And they had no thought on what they were going to do with them. Buying up physician practices, total money loser on the balance sheet. On this line item, just about every hospital loses money. buying physicians. It's the downstream effect. It's the network effect. It's the tight networks, the referral patterns, the care practice transformation, the integration, the scale. That's where the benefit comes from. Hospitals are starting to recognize that. So they're getting smarter on how they buy their practices and who they bring in. They recognize they need physicians as part of this, but it has to be the right physicians that demonstrate the right value here. But in return, they're offering things that they just didn't offer before. Back in the 90s, you were an employee. A very high-paid employee, but you were an employee. Now they're looking at physicians as partners. It's an encouraging sign. It's not an us versus them anymore. It's really getting into more of a we. Yes, different hospital systems, physician groups, there's different elements of trust. But more and more, we're seeing true partnerships develop. There are definite advantages, though, to staying independent. If you decide that's right for you, yeah, you can justify it. You're smaller, you're nimble, you're quicker on your feet. You know your patients better than any large hospital system, so you can respond. Who do patients identify with? They don't identify with St. Elsewhere Healthcare. They identify with their doctor. My doctor's Dr. Smith. My doctor's Dr. Jones. That's a tremendous advantage that the hospital, I don't think, can ever supplant. You can augment that if you choose, but you're in the driver's seat there if you choose to take advantage of that opportunity. Some questions, more fundamental philosophical issues that you'd have to ask yourselves. I won't go into these right now, but really, how are you going to survive in the future? These kind of walk through some of these. With revenue diversification, I wouldn't think of that in the sense that, we're going to open up a snow cone stand outside of our office too. No, think of how you're going to redo your model of services that you can provide. Diabetic education, bringing on mid-level providers, extending the breadth of your services into expanded outpatient centers that you may just not be providing right now. The more and more you assume risk, the more and more these things make sense. Some of these things you just can't bill for under fee-for-service. But increasingly, as you write your own contracts here, you will be able to do these things. Got to mention clinical alignment before all is said and done here. Probably an explosion of interest across the country. This is a great example of how you can really be partners with the hospital and still, at the end of the day, be the master of your own domain. Be your own boss, essentially. There's definitely a very specific definition of clinical integration that the government has. It has to be very focused on quality first and foremost. It's not just a money grab. There's a couple other hurdles that you have to participate in. But if you do, you can bypass a lot of antitrust issues, joint contracting, things that you just can't do right now. So there are advantages to this. And we're seeing hospitals even open to multi-track models. Clarion in Indianapolis has a model where you can be employed, you can be integrated, whatever's right for you. We want you in our umbrella somehow or another. And as long as we get the right care for our patients, we're not as concerned with the business model in that sense. I mean, they are, but they realize there's more than one way to achieve their goal. So what's an option? I know just in talking, it sounds like different people, probably in this room, are in different arrangements right now. But as long as these are primarily, first and foremost, care-driven, you have the choice. The writing is not on the wall in terms of, or the future is not preordained in this regard. How much time do you got? How, not for us tonight, but to transform your care? It's not an easy answer. Basically, you have to look at the market. Your market is going to determine how much time you have. You're going to have to start preparing now for these changes. These changes are afoot. Maybe you can't flip the switch in terms of starting up some of these new contracts, or maybe you'll have to figure out how to work under two different models, fee-for-service for some, full-on risk for others. But the processes take a long time to implement. And you're going to have to get started right now, is essentially the answer. Inertia is not an option. You don't want to be the low-cost provider, the commodity. It's a road to nothing, to fading away. So some takeaway questions. I'll kind of let you review at your leisure. But I do want to make sure we can open it up to questions or feedback right now. There's a lot of things that, oh man, I would love to cover. Scope. We just don't have the time, but we can talk about whatever you want.
As a primary care doc, one of my questions is, when you keep talking about being a low-cost provider, we charge, we get reimbursed by what the insurance tells us we get reimbursed. How the heck do we become a low-cost provider? That's one question. Or lower cost than we already are. And second question is, we used to do all those echoes and bone densities and all that stuff in our office, but we stopped doing it because most of the insurances didn't cover it. They wanted it done 3 times the cost in the hospital. And one of the things you were talking about revenue generating, is it something we should start thinking about reintegrating in our practices, and how will that reimbursement change? Because I stopped doing that. I sold my bone density, sold my ultrasound, stopped contracting with these physicians because I wasn't getting adequate reimbursement. So those 2 questions, low-cost provider and supplemental testing.
I think a lot of that revolves in the fee-for-service model right now. A lot of times, yes, your revenues are fixed, or your charges, I should say, are fixed. It's whatever you can negotiate from the commercial insurers. But as you start to enter more risk sharing, or when you negotiate your contracts as a group, you can say, hey, we can afford to provide this care cheaper. You know, we can negotiate commercial rates that are cheaper than the 2 or 3 times rate down the road at the hospital. Government, you're kind of stuck with that. So and if you have a large Medicare population, well, not a whole lot you can do about that. But the commercial world is the opportunity there. And then with procedures, I think don't just do them because, well, of course you don't do them just because you can do them cheaply, but if you thought that you had a value proposition before and the timing was wrong, the opportunity may be coming back. Especially, we're seeing the specialist group recognize that don't get your colonoscopy done in the hospital, do it at our center. We'll get you better quality at cheaper results. I can't remember if it was New York Times or Wall Street Journal article about a surgical center down in Oklahoma, just the other day in the paper. Great example of what can be done in the private world. Basically, is the poster child example of why independence can be a good thing.
We're always between a rock and a hard place. So now we've noticed the last few years we have these high deductibles. So now we're a cash operation. I can't offer a discount, this is our understanding, for those folks who now have to pay $2,000, meet that $2,000 before anything else kicks in. Yeah. And I would love to give, and those folks, of course, are hesitating to seek care. So those pediatric patients are not being seen nearly as often as they were before, coming in sicker, et cetera, when they finally do realize that they have to come in. Yet I'm not allowed to give a percentage discount, because then the insurance company might come back and say, well, wait a minute, really your charge is this. How do we get out of that loop? Do you understand what I'm asking here? Yeah.
Sometimes contractually, you're stuck, if that's what the contract says. We're seeing some people, the emergence of bundling, especially in the elective procedures, I'm seeing that anecdotally more and more, where people are saying, oh, the heck with it. I guess if I needed a colonoscopy this year, well, I've blown through my deductible, let's load up. And so they're trying to cluster a lot of their health care within given years. But it's kind of expensive, but not quite enough to hit that threshold. There's not a whole lot of easy options right now, short of just going to some extent even entirely outside the insurance system. Cash-only type services, which aren't practical for a lot of people.
People getting older, you go to the intensive care unit or cardiac care unit, minimum age seems to be 80, 90, 95 now. They look like intensive nursing homes with so many lines in, so many diagnostic tests. And with the aging population, less number of working young youth, do you ever think that we will be having a healthcare crisis in our country?
Our cost problems are all about economics and demographics. I don't care how red or how blue any of us are in this room. We're getting crushed because we're an older, sicker, and more expensive society. In 2021, I can say this. What do you think about single-payer health care? It doesn't matter, because in 2021, 3/4 of the volume in the hospital is going to be covered under Medicare and Medicaid. I'm not saying who's covered under what. Patients are actually getting sick and showing up at our door, 3/4. It's economics, it's demographics. We don't have any choice. That's the crush that we're experiencing in healthcare, and that's why we have no choice. but to find an answer or to find a response to that. Will it involve rationing? I don't know. I don't know. You call some of these things what you want. Okay.
Future Medicare-based value modulators, are they going to be based on absolute costs or cost changes?
It kind of depends on what we're talking about. ACO benefits, bonuses, whatnot, are based on relative cost changes. But increasingly, Medicare more and more is moving, and commercial side is moving more towards just an absolute per member per month spend. It's interesting, the more they're getting interventionalists, the more they're stepping back and just saying, population basis, how much does each patient cost on average? They've already got a report card out in, I think, 4 Midwestern states on the average cost of a primary care patient. For Dr. Smith in Kansas, on average, his Medicare patients cost us X dollars per year. That data flat out is already there. And I think it's sort of a warning shot across the bow that they're going to be looking at this kind of data, just the aggregate population end of the year data in terms of who's naughty and who's nice.
Just as a follow-up on our colleague talking about high deductible plans, in the back of my mind, I'm seeing this as backfiring on insurance companies in terms of having high deductibles from a primary care perspective and losing patients to continuity of care and eventually having problems that puts patients into hospitals, and it falls back on insurance companies. And evidently, of course, it's going to affect us, in terms of, our scorecards. How is that going to reflect on us? Our patients are not doing very well. They're not coming in the first place because they have high deductibles. I'm interested in knowing your opinion on this whole topic, and do you see this as being an issue, most insurance companies going with high deductibles for their patients?
Oh, it's a huge concern, definitely. The challenge is, what's the right way to get skin in the game, to get patients responsible, but to not create such a hurdle that they don't seek appropriate care, however we define that. I don't think anybody's figured that out yet. That's right now, most people have such a low, if not absent, disincentive threshold to obtain care. Why not? Why not run to the emergency department? It doesn't really hurt them at all. I think this is an attempt to introduce that barrier. We may see it evolve. We may see the specific numbers evolve, percentage sharing for the first whatever. I don't know. But I think it's a step in the right direction. It's not. I don't think it's the answer, but it introduces something that has been completely absent to the discussion heretofore.
Step in here.
Okay, sure. Thank you.
Is that for me coming up here or for Dr. Schlanger? Yeah, I want to say thanks to Dr. Schlanger. What a great presentation. I'd like to break from the questions for just a minute. As he said earlier, he'd be welcome to take questions individually afterwards. There's a couple more things we want to go over real quickly. I'd ask you to stay, and there's a short meeting of the MyPicked group afterwards. Just some closing comments and summarizing some of the things I heard that I hope you heard, and I want to point those out. What Dr. Schlanger has said, I've been following a lot of the advisory board. I really, truly enjoy this stuff, and I think the team that we've built at United Physicians and the administrative office really eats this stuff up. This is what we really feel our responsibility as we work for you, and we want to prepare you. And I think strategically, we need to be doing this now. Many of you have kids, I know, but with my kids in sports, I would always ask them, hey, when does basketball season start? And about the third time I asked it, my daughter was pretty quick to say, funny, Dad, it ended the last buzzer, the last game, last season. And that's really the point, that we can't wait till it gets here. The point is, we've really got to get moving forward. But population level provision of health care, definitely coming down our way. Performance driven. It's important what you do as an individual, but you will be rewarded at the population level. And it's very, very important to know that you have partners in your medical practice, but you have partners in the population health management team right here tonight, that employers and patients are now consumers. And yes, that's going to bring some scary times to all of us, but the team working together to figure out how to capture those consumers and provide the best care, bring the best value, will be the ones that win the ability to provide service to that group. And as I've said many times, that provision of care has to be partnered. The physicians in this room need to work together. The physicians in hospitals in the community need to work together. The other providers, the chiropractors, the SNFs, the PTs, all the ancillaries need to work together. One of the things we've done very proactively, our performance management committee has just kind of gone through this. We are now going to credential providers other than physicians. They won't be shareholders or owners in the company, but they will need to be credentialed. And the hope is that, and I'm going to go a little bit into some more strategy for UP, but the hope is we can provide you that list of high-value providers that you can refer your patients to. I don't think my job or our job at the corporate office is to tell you who to send people to, but our job is to provide you the data so you can make those decisions. And to share that data with you is imperative. And the last thing gets down to participation. I said this the other night, I know, but I'm going to repeat it. You know, we can build the best model, we can create the best committee structure, we can create the best experience at the UP office. We can get involved in the multitude of projects that we're currently in. But without the participation of you, the main providers of healthcare, we can't go very far individually or together. So I think there's a certain element of trusting your leadership. If I'm not doing something or the team at UP is not doing something, I would hope you would reach out to me. I'd like you to educate yourself. Education probably not the best in the doctor's dining lounge talking about how things used to be 20 years ago. I think you need to step up and talk to some of the leaders who understand this stuff. Don't continue to be part of the problem, because I know there's lots of elements of people causing this healthcare problem, but we are complicit in it. If we fix what we can control, we take out the duplicate care, we take out the unnecessary care, we absolutely provide care that's necessary for the patients, we can go a long way. And I think what Dr. Schlanger said, it really speaks, our performance will speak to those consumers seeking health care. But don't be part of the problem. Let's all be part of the solution. Let's start preparing now. Just, while I've got you here, I want to remind you that we do have experience. The PGIP program, the Patient-Centered Medical Home Program, we've been very successful getting our primary care docs ready, narrowing the variation of the way we provide care so that in a global network way we can really care for the rest of the population. We can assimilate the specialist in with the organized system of care approach. We're participating in the primary care transformation project that Dr. Schlanger mentioned a couple of times. We're one of the biggest groups in the state of Michigan in this 3-year trial. Really teaching us well about population management and care coordination of those sickest patients, that 5 to 10% that spend 50% of the healthcare dollars. We're just getting started as of January 1 with our participation in the Medicare Shared Savings Program, ACO, through the Physician Organization of Michigan. We're one of 8 POs collectively coming together to figure out how to handle population management with Medicare and Medicaid patients. And then lastly, some of you may or may not know this, but we are partnered with Alterum Institute to work on a CMMI grant regarding high-tech imaging. If you've heard one thing about our organization, about a lot of docs that work through this area, we order a lot of high-tech imaging, and that is not sustainable. So we're trying to work with the federal government, with Alterum, to find a way with some clinical decision software support, developing guidelines on how to reduce the unnecessary and duplicate imaging and order appropriate imaging. And I think we all could admit we could use a little improvement there. Lastly, I'd like you to know that UT has significant support available to you. Many of you know about the IT subsidies where we've tried to help people get on EMR, Dr. First, on Wellcentive, meaningful use assistance, especially for primary care physicians through a federal grant, care managers that now can see patients in your office, specifically through the MyPick program, but we're hoping to ramp that up and spread that out through the network. And then through our portal, which I think has had some negative reviews in the past, but the latest version coming out I think will be very helpful to you, not only for secure communication, but a community patient dashboard that pulls in data from multiple sources and directs you to a patient-centered file that no matter where a patient got labs or scans or studies, you'll have access to all of that information. And lastly, I think the data is going to be key. One of the things we've really focused on is cutting a lot of the non-core objectives that we've looked at previously in UP. I'm not saying they're bad or good, I'm just saying a different time calls for a different strategy. And our strategy is to really focus on data and informatics so that we can provide meaningful, timely, actionable data to you so you can understand what it is you're doing right, what it is you're doing wrong, and not only that, how can you correct that to go into this new delivery of health care. Providing that to you at a network level, a practice unit level, and a physician level. I think that's really what we're trying to do for you this year. I'll go through this kind of quickly, but this is kind of the strategy that I laid out to the board in February, and really what we're going to try to do to handle the transition to population management type health care. I'm not sure if these are in your packet, but I really don't want to read it, but really the bolded thing is really what we're looking for going forward with accountable care, and that is to reduce medical admissions and deliver high performance across a suite of patient health metrics. And you can read this slide, and I think you've probably seen this before, but really our current state, or in the past, has been, we have about a 30-mile by 30-mile coverage zone of physicians through multiple areas, multiple health systems. And in the past, we've really provided information to you and assistance on an individual level. Well, as you've heard tonight, this can't go forward like this. What we did yesterday doesn't work for tomorrow. The pros of that strategy, it's a large number of doctors, we cover a large geographic footprint, multiple affiliations, and we have some protection from the payers because we got a lot of people that work with us or we don't work with you. But it does promote that individualism of people doing what they want. A lot of non-evidence-based medicine. I do it this way because I've always done it, and my partner told me he did this last week. And as I said, the informatics is really geared to the individual. The future is not about that. So we're proposing going to a geographic region support structure for you. And if you look at this, we're really focusing the docs in areas of where they probably are associated with a hospital system. So if you look at the Grosse Pointe area, you look at the Troy area, you look kind of at a north and south Royal Oak Beaumont area, and then to our partners in the north, Crittenton. Because it is kind of an isolated group and there's not a lot of crossover, we want to make that its own separate region. With that, each region will be supported by a team from UP that will include IT support, a medical director, corporate analytics and informatics specialist, and a practice development consultant. That team will know every person, every practice in that region, and you will know your team. Currently, the way we do it is provide you reports, and if you're in Rochester, you can read about gastroenterologists in Novi or Grosse Pointe, but it really doesn't have meaningful information to you. Not to mention, everyone can kind of hide behind all of that and kind of ignore it, and it's hard to understand. So our goal is to give you regional-based reports where you will see people that you know, you will understand who they are, and they don't necessarily mean to call out people's poor performance. What I hope we see is you look and find where someone is performing where you're not and contact that person. Ask, exchange best practices. I think by going to the geographic areas, it also allows us to take into consideration geographic and case mix kind of differences. Population in Grosse Pointe might be different than Rochester, might be different than Royal Oak, for instance. And I think allowing us to do that will help us better understand what's going on in the region. All the while, the network goals will be the same, but we'll be able to dig down and focus to those regions and see where we can improve things. Again, I know you've been here a long time and I don't want to read all these, but I think there's just a tremendous value in approaching it as a geographic regional structure. We're looking forward to rolling this out. I know Dr. Coleman, who stepped out, has put a team together to start with our partners on the internet tonight in Grosse Pointe, since they're relatively new to UP and they are somewhat isolated to the east side. We're looking forward in the next month or so to getting out to that area and testing this new strategy. I'm going to stop there. I know it's been kind of a long night. I really appreciate your attention and all of you sticking around. I'm very happy to answer any UP-related questions. Dr. Schlanger has welcomed your questions. If you'd like to stop up afterwards, I'll have Dr. Dorr kind of moderate that. As a reminder, and maybe in about 2 minutes, if you are participating in the MyPICT program, and don't feel left out if you aren't, if you don't understand that, it's a group of primary care docs who were patient-centered medical home designated in 2010, I believe, who were invited to participate in a demonstration project with the government. We do have a distribution check of the first award that was given for this population management initiative based on care coordination. So Dr. Coleman is waiting for that group of people if you'd like to go out. If you have any other further questions, we're happy to answer them. Again, thank you very much.